You can share your slide. Actually, after a nephrologist taking up the responsibility of putting in the catheter by percutaneous PLV sheath, the number of PDs have increased, we all know. So we have the responsibility of, identifying complications and managing them also. So I thought the reason why exactly we took up this topic today. And please start, Manas. Maybe you can, you need not give introduction about various complications and so on, and you can go to the cases. Thank you, Manas. Start.
Good evening, sir, chairpersons and other speakers, and Balasubramanian, sir. Straightly going to non-infectious complication. The complications I will discuss is PD-related hydrothorax. How we managed all cases. Many of the cases were managed before I came to this institute, and some of cases we have managed after I came to the institute, and how the management has evolved over time. Because PD-related hydrothorax is a complication which has a high dropout rates. Almost 50% of the patients, if not managed well or early, then probably peritoneal dialysis will not be successful, or patient may also refuse who initially is well motivated for peritoneal dialysis because of its effective component. Patient may also deny continuing peritoneal dialysis.
Manas, make it slideshow.
Yes. So
slideshow. You expand your.
I already did, sir.
But
it's changing, no, sir.
No.
I think it is changing in my presentation.
Shailendra is saying something. The speaker has to first open the slide. Shailendra, why don't you talk?
Hello. I think my slides are changing in my desktop. It is not changing.
That was the problem that I also had, Manas.
Shailendra, I think the administrator may have restricted.
No, but my slides went through, no?
So please open your PC. Yeah.
Now it is changing.
Yes. Yeah, carry on.
Wait a second. What did you do? What did you do so I don't have the same problem?
No, it is changing now, sir.
Yeah.
Yes.
So I think, Adrian, you should not open your slides now. Whenever you share your screen, after that you open your screen, not before.
Got it.
So it is kind of thing. So,
okay.
It is clinical presentation is barely simple. Any effusion in a patient of CAPD, we should suspect even if it is early in the initiation part or it is late in the presentation part. The presenting signs, the patient may have some dyspnea or inadequate ultrafiltration. Many of our case series patients are having no symptoms. They were only detected during clinical examination or routine chest radiograph done for other reasons. Usually these patients are without any symptoms of systemic volume overload or any heart failure symptoms. Patient have relatively well preserved albumin levels, or all cases has without pleural pathology. We have to understand that in some cases, especially in our case series, 2 of our patient has infected pleural effusion, which later on turned out to be CAPD related hydrothorax. So we should understand that the incidence is around 2%, not very much. In pediatric, little bit higher, it is 3%. Particularly if it is right-sided, because most of these PD-related hydrothorax are right-sided. Very few are left-sided and can be bilateral. We have 2 cases, one cases who presented as bilateral pleural effusion. ADPKD patients who are doing CAPD have a little bit higher incidence, but we have not got this. Later on I will discuss. All larger case series shows female gender has a predisposition, and those patients who have recurrent peritonitis are at risk for this CAPD related hydrothorax. Typically almost 50 to 60% will have presentation within 30 days or 1 month of initiation, these are called early CAPD related hydrothorax. But some patient may present very late, maybe up to 2 years or up to 8 years. They can be present, some patients will present very late. Simple clinical observations gives us some suspicion that if the patient is not getting a good ultrafiltration with an hypertonic solution, or he has using hypertonic solution is increasing his pleural effusion, then that is an indicator that patient may have CAPD related hydrothorax, not other causes of pleural effusion. We can try a simple method, but it is not always true. It is less sensitive, but we can try 1 or 2 days, stop the CAPD and see whether this effusion is decreasing. Almost in 50% of the cases, we have seen that effusion decreases, but not in all cases. So coming to our experience, so we have up to 2020 we have seen, and after that we have seen another 3 patients, so total of 15 patients, but I will share my experience of 12 patients which we have published. So most of the patients in our experience are males, in contrary to other literature from Japan, which have the highest reported cases. They have reported almost 50 cases of CPD related hydrothorax. Most of our patients were male. We have not found any patient on it with ADPKD having this complication till date. And 3 of our 12 patients have history of past history of recurrent peritonitis. Most presented with some degree of shortness of breath and some chest heaviness or chest pain. And 4 of the patients have inadequate ultrafiltration in addition, and 2 patients were detected incidentally. So our large late presentation is like around 50 weeks. Average presentation was around 20 weeks, and 6 of our patients presented after 1.5 years of doing their peritoneal dialysis. Most were right-sided, almost 10 patients, and 1 left-sided and 1 bilateral. So in Indian population, probably that is some variation may be there, but as it is a small case series, we cannot conclusively say that males are predominant here, or we are getting more patients in late period of their peritoneal dialysis. So the basic pathophysiology is it is still unclear. It is well debatable. Intra-abdominal pressures are high in CAPD, as we all know. There are some diaphragmatic defects. It may be congenital or acquired. There are some abnormal lymphatic channels running through the diaphragm, and it leads to migration of dialysis fluid from peritoneal cavity under positive pressure to the pleural sepals, which is in negative pressure state. As we know, coughing or straining increases the intra-abdominal pressures to very high pressures, and this may open the channels which are usually in a normal patients, they are closed, but they can be opened with this high pressures, and it may lead to peritoneal PD related hydrothorax. Especially it acts kind of a ball valve action, one way fluid travel from peritoneal to pleural space. As we know that ADPKD patients will have a huge kidneys with higher intra-abdominal pressure when they do CAPD. So probably they are prone for this complication. And what are the communications? There are several autopsy findings. There are several hypotheses. So summarizing everything, so it may be congenital, it may be acquired, or it may be some abnormal lymphatic channels which run through the diaphragm. So not going into details because these are all we cannot diagnose it before starting the peritoneal dialysis. So this is all for theoretical discussion. So coming to pleural fluid analysis, this is the first reflex step with any pleural effusion in a patient of CKD or on CAPD. So initially, like physicians were morely dependent on pleural fluid analysis and trying to find out whether this is related to peritoneal dialysis or it is related to other causes. So like other transudative pleural effusion, we have to exclude in all patients, which is very common in our CKD population: congestive heart failure, severe hyponatremia, cirrhosis, or fluid overload states. But in PD related hydrothorax, most of are transudative effusion unless they are infected, secondarily infected due to either iatrogenic or spontaneously. In our case series, we have seen 2 of our patients have spontaneous secondary infections. We cannot find out any event which led to any iatrogenic event which led to secondary infection of this hydrothorax. So effusions are usually transudative. Even if we apply the Light's criteria, then most of the patients will be coming in the transudative category of effusion. So what has been classically taught to us and what has been used in past is glucose level analysis. So 2 things are used: either pleural fluid to serum glucose gradient or a ratio. So various publications have shown various sensitivities and specificities, but what can be now told with a very good confidence is if it is greater than this glucose gradient is more than the difference is more than 100 milligram per deciliter, then it is almost diagnostic. But we have to see that almost 20% of patients will have also less than 50. This is because of probably reabsorption of glucose from the pleural space. Some authors suggest this ratio is more sensitive than this gradient. So many older publications will like depend on greater than 1, they will diagnose. So many authors have also tried to improve this diagnostic method by using 4.25% dextrose solution. But currently this method is very doubtful and probably not used. So what in our case series, what we have seen that out of our 12 patients, 11 patients were classified as transudative according to Light's criteria. Only 1 patient has classical empyema feature, which he was also culture positive. So probably it is kind of a secondary infection, either spontaneous or iatrogenic. As it is a retrospective case series, we could not find out what was the exact cause. And coming to the PFS glucose gradient, so almost 66% of the 8 patients have more than 100 and 4 patients have 50 to 100. We have not found any patient who has less than 50. And all patients have this glucose ratio of more than 1. So probably this holds true in our case series. Some innovative methods which is currently not used or not available, just for the sake of knowing, is methylene blue installation in the peritoneum was done, and we can the diagnostic tap in the pleural space can be done, and we can see this dye in the hydrothorax. So because of risk of sterile peritonitis, it is not used now, I think. If patient is on icodextrin, then probably this glucose gradient method will not work. So it is a simple step. We can get a diagnostic tap and we can add some povidone iodine to the aspirate. And if it turns blue, blue is black, then it is a valuable test. It is a valuable and simple test. Also, some authors, some Japanese authors have shown that L-isomer of lactate is endogenous, whereas D-isomer is exogenous, which is present in CAPD fluid, can be used to differentiate between whether this is an effusion or it is a PD-related hydrothorax, but it is not clinically available for routine use. So coming to the diagnostic or confirmatory modalities, which is usually used, and we should know about these methods. Previously, plain radiographs, contrast catheterograms, and peritoneographs were used. Probably I have not seen in my institute. We usually use CT peritoneography or nuclear isotope scans. we seldom use MR peritoneography. It is more costly and more cumbersome for the patient. Based on sensitivity, specificity, and all case series, probably with cost, it is the best diagnostic modality because it can be done in the next day. When we suspect, it can be done in the next day only. Isotope scans, again, the availability may be limited, the cost may be more. So these are only now currently reserved for the patients who are probably who has a good residual renal output. We don't want to give a lot of contrast, or maybe who are allergic to the contrast. MR peritoneography, also in Western literature, there are some case reports who have used MR peritoneography. Gadolinium, as we know that it may cause nephrogenic systemic fibrosis, so it is not preferred. But T2 weight images can use water as a contrast medium, so it becomes PD fluid as a contrast medium because it contains electrolytes. So it may be a good method where we want to altogether avoid any type of contrast or isotopes. In our case series, out of 12 patients, we have initial periods like in 90s and in early part of 2000, we have used scintigraphy as a primary methods, but currently we are mostly using CT peritoneography for diagnostics because it is easy and it can locate the exact site of the defect, and it also helps in planning repair. So we are not currently, last 3 cases, we have not almost used scintigraphy. CT peritoneography is like the dose of contrast is 50 ml per liter. So almost 100 ml we have to use, and pre-scans and post-contrast scans are taken, and patient is asked to ambulate for 60 minutes so that the intra-abdominal pressure increases and the sum of the contrast goes into the pleural space. If the patient is non-ambulatory, then the patient can be asked to roll from side to side for at least 30 minutes. We can use larger volumes. We have not used in any of our patients. Advantages is it can locate the defects, even a small leaks it can detect. In addition, we will get other features like adhesions and loculated collections in pleural space or intra-abdominal space we will get. IV contrast also can be used if we suspect or patient has features of any pleural pathology like malignancy or any loculated effusion or abscess. So this is an advantage over nuclear scans. So the limitation is it's not if catheter obstruction or catheter related obstructions, we will not get any information. So that is a limitation. Anyway, it is a limitation with also nuclear scans. And in pediatric population, probably CT peritoneography will have more radiation. Coming to peritoneal scintigraphy, some amount of tactinium scans. We have used macroaggregated albumin or sulfur colloids into the peritoneal cavity, and multiple projections are taken. Analysis is little difficult. Only experienced persons can locate whether it is in the posterior part of diaphragm or anterior part of diaphragm or lateral part of diaphragm. So location of the leaks are very difficult to know. Exact site may not be known by this peritoneal scintigraphy. Also, delayed images have to be taken in this, so it becomes very cumbersome to do a nuclear scan. Many of the times, in 3 or 4 of our patients, we have initially done nuclear scintigraphy, but later on we have to go for a CT peritoneography again. So same methods are used to increase the sensitivity of this method. So basically, if the scintigraphic radiation goes above the hemidiaphragm, so we consider as positive. So this is images of our one of our patients that we can see one small bulb in the in CT scan. So it's this it can be measured in Hausfeld units, and a radiologist can tell that, okay, this is in the pleural cavity above the diaphragm. So also multiple coronal sections, lateral sections we can see. So exact site of the diaphragmatic defect can be seen. So it helps in planning of the definitive management. So coming to the management part, it depends on how severe the symptoms are or how acute the symptoms are. If the patient is very breathless or very severe symptoms, then a acute thoracentesis is required. A large volume of fluid has to be drained out and CAPD has to be stopped immediately. But many patients will, if we stop the peritoneal dialysis, then many patients get symptomatic relief. There is no need to do
गर्मी से पक जाएंगे वो हो जाएंगे.
The conservative management options includes the temporary shifting for 4 to 6 weeks on hemodialysis, as this peritoneal fluid is an irritant to this diaphragm. So ongoing fibrosis occurs, and the seals early leaks or small leaks may fibrose and can heal themselves. So there is no requirement of doing any invasive procedure or pleurodesis or any surgical procedure. This some case series shows that almost 50% have 50% of the patients have spontaneous resolution of hydrothorax. But in our case series, we have not seen this in our population. I will show. And in many patients who have a good residual renal output, or those who are going for a renal transplant very early, and small amount of hydrothorax, can continue peritoneal dialysis. One of our patients who has no vascular access and she has no choice of any other modality, no transplant prospects, still continues on peritoneal dialysis with some amount of hydrothorax still present in her lungs. So coming to the procedure of choice in current era is video assisted thoracoscopy surgery. Either it can be a surgical repair or a stapling or suturing or a patch or a fibrin glue or sclerosing. It depends upon the surgeon's expertise and size of defect. So it is both diagnostic and therapeutic. And the best part is that intraoperative evaluation for the leak, whether it has closed or not, can be done during VATS. So that is the best thing, that whether the defect has been adequately treated can be known by this method. So it is almost 100% successful in our cases, and it also causes less pain, less morbidity, early discharge from the hospital, and usually after 2 to 4 weeks we can restart the procedure. So this is actually images from our patients. So as in the second slide, we can see a defect, the peritoneal, a diaphragmatic defect, which was sutured and it was closed through VATS. So this is in past, many of our patients underwent conventional pleurodesis, in which a thoracostomist tube was put and all the fluids were drained. Once the lungs is dry, we put tetracycline or betadine into the pleural cavity, and patient is asked to undergo a special set of movements, like to disperse this talc or tetracycline to the entire pleural surface. And this usually caused a severe pain, probably. So a local analgesics and systemic analgesics has to be given. This method also fails. Many of our patients failed chemical pleurodesis in earlier era. So this has almost 50% case. And if this peritoneal dialysis is started after 2 to 6 weeks, similar to VATS. Open thoracotomy probably is not done now. It has obviously 100% success, but high morbidity in especially our patients, ESRD patients. So it is not preferred now. So in our cases, as we can see from case 1 to case 12, case 1 to 7 is like it is in before 2001 or 2005. So mostly we stopped the peritoneal dialysis, and we tried with either wait and watch or permanent shift to hemodialysis, or like tetracycline or betadine fluorouracil. Then CAPD was restarted in many of the patients. Many patients have recurred, so they either were permanently shifted to hemodialysis, or many patients like underwent transplantation after that. But after case number 8 to 12, almost we are offering all our patients for VATS repair. So out of this 5 patients have undergone VATS repair, and successfully 3 of our patients now on this case series are still continuing peritoneal dialysis. So concluding, diagnosis is easy but require high index of suspicion. Even if a patient is presenting very late in the course, we should suspect it may be a PD related hydrothorax. CT peritonography is probably the investigation of choice, because it is cost effective, early, and localizes the defect. Conservative management for at least 2 to 6 weeks. If not, then VATS is the treatment of choice. And recently we have published, as Balasubramanian sir told. So I thank Professor Amit Gupta, because like many of these cases are his patients, and many of these cases are Narayan Prasad sir's patients. So thank you all. Concludes.
Thank you, Manas. Actually, I have put this paper up in the WhatsApp group, so you can leisurely read the others. And I think we'll spend another 5 minutes or so on discussing this. From the chairpersons first, your experience on this. Left versus right, does it alter the choice of therapy?
Amit, you want to go, or you want?
You can go ahead. Yeah.
Yeah, most of them are generally they're right. So it's as it is, the incidence is very low. And if I may say, from our clinical experience, most of them have been small effusions, which with the cessation of therapy for about 4 to 6 weeks heals, and then we can restart with the lower concentrations. But the approach is the same, whether it's right or left. VATS, it's definitely CT. It's pretty standardized. I think the isotope DTPA, the study, the scintigraphy is difficult anatomically to what you call identify it. So I would say CT has taken over, and it's very clear cut, and you can see as the speaker showed, and the approach is the same. And you find the it's called the foramen of Botch-Delac. I think it is the patency of the foramen of Botch-Delac, which is which opens up, and because of the hydrostatic pressure, you see the seepage. And one of the tests we used to do is to also, I mean, there are so many easy tests, the glucose and all those things, but also when you try to use hypertonic glucose, the effusion increases, the patient becomes any mechanical leakage of PD fluid that can be diagnosed and confirmed by even increasing the tonicity of the PD fluid. I would think the VATS is the standard procedure now in most centers, and they generally like to stitch it after identifying the defect.
Okay. Any other comments? I welcome Dr. Vijay Sri Narasimha. You can unmute if you want to make any comments, Vijay. Okay. Any other questions from the audience?
I just wanted to add that early on, as Dr. Manas has said, that we used to do this nuclear scintigraphy. That was the standard of diagnosing. But what you should, I mean, it's important for the younger people to realize that whenever you have a patient who comes to you with a poor ultrafiltration, which happens suddenly, and some history of breathlessness, then do suspect some sort of a pleural leak or a leak into the abdominal cavity, the abdominal wall or into the genital area. Now, if you have a patient who complains of breathlessness in addition to the reduction in the ultrafiltration, get a chest X-ray done, which will help you to identify the problem. And early on, we used to, I mean, when we did not have VATs, then we used to sort of, our cardiothoracic surgeons would instill either talcum powder or some sclerosing agent, which used to be very painful for the patient actually. And then we used to wait for about 4 weeks before we could restart the patient back on peritoneal dialysis. And when you restart it, you start with small volumes and then increase the volumes as the time passes.
Okay. Now, with the availability of VATs, should we try pleurodesis first, then go on to that, or because of the morbidities caused by pleurodesis, should we skip that and go for VATs? Or
I think if the leak is first, the first approach will be to cessation of PD temporarily, and most of them heal. So that would be the first one. And putting in talc and all are also not easy procedures and very painful, as Professor Amit said. It's very painful. That is only when you do it you realize. So I would say rest from PD would be the first approach, unless the PD pleural effusion is massive. Then I think straight away you can go for what do you call intervention rather than rest. So you tap it, diagnose, and then you go ahead and do the surgical procedure.
okay, thank you. I think Adrian, you can share your